Okay, so this part we're going to talk about schizophrenia. And schizophrenia, we normally think of it as, well, what do you guys think of when you think of schizophrenia? Hearing voices, so that's hallucination, right? Okay. So schizophrenia, you said hearing voices, so that would be hallucination. And maybe they're like delusional. Okay, so these we actually consider them to be positive symptoms. Positive as in they kind of have something that normal people don't have. I mean, normal people don't really have hallucinations, and these people have hallucinations. They have delusions. Okay, so I think that's where the term comes from. So positive symptoms. And then there's another set of symptoms that's basically described as negative symptoms. So these are like stuff that they're lacking that most people have. So, for example, these people are really withdrawn, social withdrawal. And they don't really talk as much, lacking speech. So these are speech. So these are considered negative symptoms. And whenever we think about the positive symptoms, we kind of attribute to the effect of dopamine here on emotions and the reward system. So schizophrenia, we're thinking that since they're getting these symptoms, they actually have too much dopamine. So schizophrenia, these are attributed to too much dopamine. And we're talking about specifically different parts of the brain in the ventral tegmentum area and how that feeds into your emotions and your decision makings, your thinking. Are there any questions? Okay. So this is somewhere else in the brain that's affecting their emotion, their hallucinations and stuff like that. And just to be clear, people who are schizophrenic, they don't really have the movement problems, but these two areas are both controlled by dopamine, but it's only specifically places affecting emotion and rewards are affected in schizophrenia. And then there's a set of negative symptoms. So the negative symptoms we think of as having something to do with serotonin, so 5-HT. We're thinking that serotonin has something to do with these negative symptoms. So the drugs that we're going to give these patients, there's two groups of drugs, and then they kind of address the negative and the positive and the negative symptoms of schizophrenia. So let's start with this one here, the positive symptoms. If it's due to too much dopamine, you can imagine like when we're trying to alleviate their symptoms, we're going to try to decrease the dopamine, right? So we want to, to address the positive symptoms, we want to decrease dopamine. And if we decrease dopamine, we can't do it so specifically that it only targets the emotions and the reward center. We're going to inadvertently target here as well, the movements. So that's some of the side effects that we'll go into. And the first class of drugs that's used to address the positive symptoms are the first generation or the typical antipsychotics. So these are typical. Or first generation antipsychotics. And there's a pretty big list in your in the lectures, but there are two really important ones that you must know. So there's the chlorpromazine, and there's haloperidol. And these are the two that shows up the most out of everything else in that list. So I would definitely prioritize knowing these two first. So these two, since they all address this, they all try to decrease dopamine, they will cause a lot of these movement problems. So if their movements are normal to begin with, and then now you blocked their movements, what would you expect? Would they appear like they're, if you blocked dopamine in a normal individual, would they get like too much movement or too little? Okay, so yeah, not yet. So first you would expect, okay, so if they're decreasing dopamine, that's essentially like giving them Parkinson's disease, right? So Parkinson's disease is basically they can't make enough dopamine and they're not moving so much. So first they're gonna get something that's similar to Parkinson's, so like pseudo Parkinsonism. So that's basically, not moving as much. And then they go through several other steps until, so this is acute. And then these are all adverse effects of the treatments. So first, it's acute pseudo-Parkinsonism. And then eventually, the receptors for dopamine is going to get upregulated because they're thinking like, well, we're not getting so much stimulation. So the receptors are going to upregulate, and then they're going to end up with lots of dopamine, increase dopamine receptors. And eventually they're going to be really sensitive to dopamine. So if they're really sensitive to dopamine, they have a more pronounced response to dopamine, then what would you expect? Then you can say your tardive dyskinesia. Okay, so increased dopamine receptors, and then that's increased response to dopamine. Then chronically, what you will get is over a long period of time, these people will end up with tardive dyskinesia.
Do you guys know how it looks like?
So, show and tell.
It's the same thing as Huntington's disease. So Huntington's, there's like Elizabeth's and they're like this, and then they're like
Korea.
Like that, and then they're like wandering around, and then they can't stop moving. That's Huntington's disease. But when you have tardive dyskinesia, it's the same thing. The only difference is that one is drug induced.
So you basically, because the receptors kind of got upregulated, they're responding to dopamine more than before, and they're actually having a more greater than normal response to dopamine. So that's why they end up with these Huntington symptoms. So tardive dyskinesia, it's almost like drug-induced Huntington.
So because we're reducing the dopamine in this person, how do these receptors, they become super sensitized, I guess?
Yeah.
And what dopamine are they reacting
The very little that's there.
The dopamine that they're actually making.
in the body?
Yeah.
Okay.
Because so these are the typical antipsychotics, they're only blocking the effects of dopamine. They're not actually doing anything to what's being made.
Are they competitive antagonists or
No, I'm not quite sure actually. Yeah. I can check. I don't know if it's something that was really stressed.
That was stressed.
That was not really something that was stressed. They just said it blocked these receptors.
Is there like a neuroleptic something also?
Yeah, so that's somewhere else in the brain. So yeah. Okay, so
That's something else.
that's something else.
Yeah,
We can talk about it. Yeah. Yeah. Haloperidol. So haloperidol will give you more of the dopamine, these symptoms. Okay, so with regards to movement, they usually call these like the extrapyramidal symptoms. So extrapyramidal symptoms. And in addition to these problems, so these are like the movement disorders, drug-induced movement problems of some sort, right? So these are movement. You can also get problems elsewhere. So remember we went back in the very beginning, we were saying that here dopamine has something to do with the reward system. You feel happy when, yeah?
Could you also include akathisia as far as
That's one of the steps in here before it gets to tardive. Yeah, there are other steps involved too. Akathisia, there's dystonia too. Yeah. It's part of the movement abnormalities, drug-induced movement abnormalities. And akathisia, dystonia also occur a little bit earlier on, but the end result, if this goes on for way too long, is the tardive dyskinesia, and that's the irreversible one. Yeah. Okay, so those are all with regards to movement abnormalities. But dopamine is also involved in several other places. So we were talking about up here that dopamine is involved in emotion and reward. So the reason why some people get happy when they take drugs is because of the dopamine. So if you block that, you would imagine they could be really unhappy, so like dysphoric. So mood, its impact on mood and emotion would be basically described as kind of unhappy. Anhedonia, right? So generally unhappy due to the effects on the ventral tegmentum area. And if you guys remember, dopamine is also in certain other parts of the brain too. So the part in temperature regulation, hypothalamus and temperature regulation. If you change that, you can imagine that there will be some abnormalities in temperature. So malignant hyperthermia could be a side effect. And the treatment for that would just be what you normally treat malignant hyperthermia. You can use dantrolene and you can use supportive treatments, or you can use some dopamine agonist. So dantrolene, supportive, or dopamine agonist. That's what you would use to manage that. So this is one thing, these are the different categories of adverse effects. And in addition to that, if you guys remember, dopamine is normally used to suppress prolactin. So normally dopamine suppress prolactin. And if you don't have enough dopamine, if that's being blocked, you can have increased prolactin. Okay. So if you have decreased dopamine, the prolactin would increase. And you can have some gynecomastia, amenorrhea, things like that. Galactorrhea too, yes. Rhea? I don't know if I'm spelling this right. And then gynecomastia, amenorrhea, things like that. So these are the other side effects that you can see that are other parts of the CNS that's also affected by dopamine. So these are anything that blocks dopamine, you can expect the same set of symptoms. And we're talking about it here in terms of the typical antipsychotics because they have more dopamine blocking activity. And then now we're going to talk a little bit more about this social withdrawal and the negative symptoms. So these are one set of drugs, typical antipsychotics. Actually, I'm gonna pause this right here.